So when we talk about the valves, we're talking about the mitral valve or the bicuspid valve, which is on the left side. When we talk about the tricuspid valve, that's on the right side. What stenosis is a hardening of the valve, and also when it hardens, the opening area gets very small. So remember, we went through how the blood flows through the heart. The blood that's coming in through the left atrium, the blood that's coming in the left atrium is oxygenated blood from the lungs. So after it leaves the left atrium, it's supposed to go through the left ventricle via the mitral valve. Now, if the mitral valve is very small and hard, what's going to occur is that the blood cannot leave from the left atrium to go inside the left ventricle. So what's going to happen is that the blood is going to back up into the left atrium and then back into the pulmonary system. And that's where you get your congestive heart failure again, because you're going to get pulmonary edema, you're going to get fatigue, dyspnea, difficult orthopnea. When they are lying flat, going to have difficulty breathing. So let me say this again. In mitral valve stenosis is a hardening of the valve, and the area also get narrow. So what's occurring is that the blood the way the blood needs to pass, go into the left ventricle, it is having difficulty. So when the blood here that is supposed to go into the left ventricle not going, you have other blood coming in. So it's going to accumulate until it's going to back up. It's just like traffic. It's going to back up back in the lungs where it's coming from, and that's where you hear your crackles. For regurgitation or insufficiency. By right, when the ventricle with a healthy heart and a healthy valve, when the left atrium contracts, the ventricle is supposed to relax so that it can catch the blood. Not only that, you have the valve, the mitral valve opening. So if the mitral valve is open and the blood going through the mitral valve into the ventricle, when the ventricle is going to contract, you're going to have that the valve is shut. The valve is going to be shut right here to prevent the blood from backflowing into the atrium. Okay? So when that occurs, it prevents the blood from backflowing into the atrium. And in mitral valve insufficiency or mitral valve regurgitation, the valve here is not working, and so it doesn't shut when the ventricle contracts. A matter of fact, it opens. So what happened is allow the blood to backflow back into the atrium, and it causes the same thing. So with the blood that's going back, you're going to see that the atrium is enlarged, plus more blood is coming in. So you're going to have the same congestive heart failure, such as in like this left side, you're going to have crackles in the lungs, dyspnea, and all of that, fatigue. With this is called the mitral valve. When it becomes narrow, the blood cannot pass from the atrium to go inside the ventricle. So what's happening that it's not emptying completely, so you still have blood inside there. Then you have blood coming from the lungs coming inside there on top of what's inside there. So by that occurring over and over during the cycle, you're going to have the atrium swelling. And then when it swells and can't hold anymore, you're going to have the fluid backing up back to the lungs. And when it backs up to the lungs, they're going to have difficulty breathing. You guys are going to hear crackle when you put your stethoscope and so forth and so on, okay? Now, another thing a similar thing occur when it comes on to regurgitation. Regurgitation is when this doesn't close as it should. And because it doesn't close, what you find that is blood is going back. When the ventricle contracts, the blood is going back into the left atrium, and the same thing is occurring again. It's the same with the trichopsin stenosis and trichopsin regurgitation. Trichopsin is not that common as mitral, but it's the same thing. When there's a accumulation, say this is stenotic, the blood does not drain from the atrium, it's going to back up back in the system, and it's going to go to the neck, having distended jugular vein. It's going to go into the superior vena cava where the blood is coming back from, backing up back in there. So you're going to have ascites, hepatomegaly, and even peripheral edema or edema in the lower extremities. So whether it is stenotic or whether it is regurgitation, you're going to still have the same outcome but different cause. And I said that this morning, what that looks like is a person who wants to have a baby, and they can have a baby two ways. One, by having sex, and another by in vitro. It doesn't matter if they're going to have a baby. So the same thing that we're having two problems, mitral valve stenosis, which is a hardening and a narrowing, mitral valve regurgitation or insufficiencies where the blood is back flowing into the atrium, but you still have the same outcome. So we said that the mitral valve is a thickening, get narrow, and blocking blood flow from the left atrium to the left ventricle. That means not enough blood is going. So of the clients with mitral valve stenosis, 2 out of 3 are females, and most causes of mitral valve stenosis are caused by rheumatic fever. So it can be mild and asymptomatic heart murmur. It could be moderate to severe stenosis. So symptoms of left-sided heart failure due to the blood backing up, and we talked about this already. They will have coughing, they will have orthopnea, they'll have history of propping up on pillows to sleep, or they may say that, you know what, I have to be now sleeping in my recliner. So they'll complain of weakness, fatigue, palpitations, mild weight gain. Diagnostic Test, they'll do a physical and history and a physical. So they'll do an ECG to find out left atrial enlargement and also right ventricle enlargement. Now you may say, why right ventricle enlargement? Let me go back to this photograph here. This one. When someone have right-sided heart failure, most of the time is caused by left-sided heart failure. Even though we talk about the heart in one chamber at a time, they work together. When the atriums are contracting, both atrium contract. When the ventricles are contracting, both ventricle contract. So what occurs is when the blood backs up back in the lungs, then it's going to back up back into the right ventricle, because remember that the blood comes from the right ventricle to go to the lungs also. So you're going to have the blood backing up. So that's how the right ventricle get involved, and then will be swollen or stretch or dilate, because left-sided heart failure causes right-sided heart failure also. They'll do a echocardiogram, receive mitral valve, reduced mitral valve area will be noted. They'll also do a cardiac catheterization. Coronary artery normal if there's no other disease. So with the catheterization, cardiac cath, they actually go through the femoral artery up into the heart. All right. You want to make sure that you check the pedal pulse. And I was telling the class this morning is that you want to make sure that you do an assessment before you go in, because some people you cannot find a pedal pulse on them, and they're pretty normally healthy, and you have to get a Doppler. So if a client is going to cardiac surgery, you want to make sure, is this person, can I get a pedal pulse even before they go in? So when they come out, and if you don't get one, you're not surprised. If you don't get one by palpating with a finger, you know you're not surprised. You need to get a Doppler to test it, because this person normally requires a Doppler. They'll do a chest x-ray too to see the enlargement, cardiac enlargement, and also the cardiomegaly. So we're going to go over this treatment, and this treatment is used for stenosis, regurgitation of mitral valve, and the Trichopsin valve. So they use a doable pneumonic, and the doable, the D, they give diuretics to relieve pulmonary congestion, fluid overload, and return to baseline. They also give oxygen to correct any kind of hypoxia. They give ACE inhibitor to reduce preload and afterload. And they also give beta blocker to prevent any kind of arrhythmias and to reduce the workload of the heart. Let me tell you that ACE inhibitor, a couple of things, side effect of ACE inhibitor. Dry cough. It can also cause rebound edema too. People can have edema with ACE inhibitors. And ACE inhibitors are like our pills. Okay? So low sodium diet to prevent fluid accelerated BSN program. So they're just learning how to listen to the heart rate and so forth and so on. So this student came to me and said, Dr. Perez, I think her heart rate is irregular. And when I went there, so be it was irregular, but no, there was no documentation in the chart, nothing at all about the heart rate. So there and then we notify the nurse. But I'm saying that if you do not do your assessment on the client, when something take a turn for the worse, you won't know if it is something new happen or not. So you want to have a background assessment, a baseline assessment, so you can compare it to something else. For valvular repairment or valvular surgery, they will watch for hypertension and arrhythmias. They'll titrate anticoagulant using the PT for heparin and the INR for warfarin. And they also use PT INR for warfarin also. So what they'll do, they'll titrate the levels, especially when anyone have any kind of replacement of any like surgical valve or anything. They're going to put them on Coumadin. They may start them in the hospital in heparin, but when they go home, they're going to go on Coumadin for the rest of their life. So you want to have them report any findings of any kind of heart failure to the provider, like weight gain and worsening with this any kind of fatigue or osteopenia. You want to have them report. Adherence to cardiac medication is essential to stay healthy. Low sodium diet, about 2,000 milligrams per day. If client is on long-term anticoagulant, then we want to do periodical lab testing. If INR for warfarin, they want to make sure that you maintain a steady dietary vitamin K level and to report any signs of bleeding. When someone is on Coumadin, you do not change the level of vitamin K. They maintain whatever level they have, because if someone comes inside the hospital, they're going to draw their PT, their lab values, wherever it is, PT, INR level, with whatever the diet they have. You know what I'm saying? When I come in, they don't ask me what's your diet and adjust my levels according to my diet. So they're going to take my PT level with whatever diet I have, and that's how they're going to monitor my levels and adjust it accordingly. So if the person is on Coumadin, you don't want to tell them to decrease their vitamin K, because when they came in, they didn't decrease their vitamin K. You understand what I'm saying? So you monitor, though. You don't want to increase, you don't want to decrease, you just want to make sure that you. And also the potential need for antibiotic before any kind of dental care or any kind of invasive procedure. The person will get antibiotic prophylactically. So nursing intervention and assessment. So if the client has had valvular surgery, you want to watch for hypertension. Okay, so mitral valve insufficiency or regurgitation, we'll talk about that. This is when the blood, there's like incompetent valve, and the blood, when the ventricle is contracting, the blood backflow into the atrium. Okay, and so what this does is cause the atrium to stretch and having the blood backing up back into the system. So you're going to see that the manifestation is similar like the mitral valve stenosis. So follows birth defects such as transposition of the great artery, the aorta and the pulmonary arteries are switched. This is one of the causes that could occur that causes it. It occurs in 5 to 10% of adults. The findings, the client may be symptomatic, osteopenia, dyspnea, weakness, weight loss, chest pain. And I know you see weight loss, you may say, what? With blood transport nutrients and any kind of deficit or so forth. So they may, one of the most common thing that you'll see is weight gain because of the blood backing up back in the lungs. But you most likely see weight gain with the right-sided part of the heart because of the ascites, the pulmonary, the extremity, the edema, the distended jugular vein. When they have pulmonary congestion, you more likely see weight loss because the fluid is not there to transport the nutrients as it should, especially if it happened over a period of time. So most cases you see weight gain when you have right-sided heart failure. So epidemiology, systolic murmur at the apex, high-pitched blowing murmur may also radiate to the axilla. They'll have jugular vein distension. They'll have pulmonary peripheral edema, epitomegaly. Remember that left-sided heart failure can cause right-side heart failure. Okay. So diagnostic test. They'll do an ECG for arrhythmias, and changes of left ventral arterial enlargement will be noted. They'll do an echocardiogram, which will show that the blood is backflowing. They'll also do a cardiac cath, which we spoke about earlier on, and they'll do a chest x-ray to show that they have cardiomegaly or pulmonary congestion. If a person's going, there's no NPO for x-ray, but there are certain things, like if a person is pregnant, they can't do an x-ray. They have to cover the person's genital area when they're going to do an x-ray, and they have to remove piercing bra and put on the facility gown. And again, the durable is a part of the treatment. They'll do the diuretics, they'll do the oxygen, they'll do the ACE inhibitor, they'll do the beta blocker, low sodium, and exercise. And it's the same treatment for, and as you can see, same thing with warfarin or Coumadin. Dietary levels, you want to make sure the vitamin K is maintained, not increased, not lower. It's the same concept for it. The tricuspid valve stenosis, which we spoke about, stenosis is a hardening and narrowing of valves. So what happened is that the blood will back up back in the system. So it's going to have distended jugular vein, have hepatomegaly. They will also have peripheral edema, and so ascites. And so one of the major causes, as it says, is rheumatic fever, just as with mitral valve stenosis. Okay. So the same treatment for it is the same. The doable, diuretic, oxygen, ACE inhibitor, beta blocker, low sodium, and exercise. Regurgitation. Regurgitation of the tricuspid valve, as I said before, it is the same signs and symptoms, however, different cause. This is where the blood is. The valve is not shut in when the right ventricle contracts, so the blood is backflowing into the atrium. And when that occurs, you're going to have a backup, and the manifestation are the same. This is common in IV drug users, people with congestive heart disease, or even can be from rheumatic fever also. Again, it's the same distended jugular vein, peripheral edema, just like a repeat. It's the same signs and symptoms. So we're going to talk about pulmonic stenosis, and the concept is the same. And we're going to talk about aortic stenosis, and then we're going to do some questions. So keep in mind that when we talk about stenosis, while it's a different part of the body, it's the same thing that's going on with the pulmonary valve. So what's happening is that the pulmonic valve, the deoxygenated blood is coming from the right ventricle through the pulmonary artery to go to the lungs to get oxygenated. So when it's stenotic, what's occurring is that it is narrow and the blood cannot go up to the lungs, cannot go through the pulmonic valve. So what's going to happen? It's going to back up back into the right ventricle, back up back into the atrium, and back up back in the system. So what you still have is still edema, ascites, distended jugular vein. I don't know if you guys understand what I'm saying. In order to understand the concept, you have to know the function of the heart. Because remember, the blood leaves from the right atrium, goes to the right ventricle, and goes through the pulmonic artery. If the pulmonic artery is blocked, then the blood is going to go back where it's coming from and back up back in the system. So epidemiology is usually congenital, often occur with other birth defects such as tetralogy of Fallot. So also, even though they have pulmonary stenosis, and this is a perfect picture, I think. Here, the blood comes from the inferior vena cava, the superior vena cava dumps into the right atrium. The inferior vena cava dumps into the right atrium. Then it goes through the tricuspid valve into the right ventricle. It leaves from the right ventricle to go to the pulmonary artery. But when this is blocked, when this area is blocked, the blood cannot go in. So the blood back into the system, back where it's coming from. So you still have the sign of edema, ascites, hepatomegaly, and all of that. Okay, but what they're saying, pulmonic stenosis occur with tetralogy of Fallot, where you'll have displaced aorta. You may have also ventricular septum defect where there's no septum. You may also have thickened ventricular wall. So it's rare among the elderly, and it may result also from rheumatic fever. So finding may be cyanosis, dyspnea, fatigue, syncope, finding of heart failure, cyanosis, and also failure to thrive may occur. So diagnostic, they'll do an echocardiogram, which will show that there's some abnormalities and with increased right heart pressure would be noted. So if the client is on long-term anticoagulation, Periodically lab testing will be needed done. They need to maintain a steady dietary vitamin K level and report any sign of bleeding. You do not use a safe razor. You use an electrical razor. A safe razor have a blade inside here that can cut if someone is on Coumadin. And you want to also explain the potential need for antibiotic prophylactically before any kind of dental care and even kind of invasive procedures. So again, we have pulmonic insufficiency or pulmonic regurgitation. In the same pulmonic valve that I show you that at stenotic, what's happening is that when the ventricle contracts to push the blood to the pulmonic valve, it regurgitates and come back out. And if it comes back out, not enough blood going to the pulmonary system, and you're going to have blood coming on it, so it's stretching, and so it's full to the back up to the atrium, and then back into the system. So again, the epidemiology is still birth defect as a result of pulmonary hypertension. It's really result of prolonged use of pressure monitor catheter in the pulmonary artery. So with this, what they're saying is that pressure monitor in the pulmonary artery can cause it, because regurgitation is that the valve is not closing shut. So when it's incompetent, and so findings, they will have chest pain, they will have fatigue, syncope, peripheral edema, because even though it's different from the Trichopsin regurgitation or the Trichopsin stenosis, it still have the same effect. Because if the blood that is supposed to leave the ventricle and go through the pulmonary artery is not going, it's going to back to the right ventricle, back to the right atrium, and then back in the system. It is very important that you understand the function of the heart, all right? Because that will help you with signs and symptoms of, what will be versus the pulmonary system versus the external system, like the ascites or the epitomegaly or the distended jugular vein, if you know where the blood is flowing from. So again, as you can see, the concept is the same. If they're on Coumadin, maintain a steady vitamin K level and also monitor sign of bleeding, and also they need prophylactic dental care. Let's look at this. Aortic stenosis. With aortic stenosis is that it's the valve, one of the semi-ulnar valve of the aorta is stenotic, meaning that it becomes narrow, it's caused poor cardiac perfusion, and also increase in left heart pressure. So etiology, so most significant valvular lesion among the elderly people. It is usually the leading cause of left side heart failure and left ventricular atrophy and cardiomyopathy. So the incidence increases with age versus when it's pulmonic stenosis, you see that it was mostly congenital. Occur in 1% of the population. It's about 80% of these people are male. So for the classic triad, they'll have dyspnea, syncope, angina, fatigue, palpitation, because what's going to happen with this is that when we talk about stenosis, that means what's happening here is this stenotic, the blood is not going to go into the aorta to go out through the rest of the body. It's going to back up into the left ventricle and then back up in the left atrium to back up in the pulmonary system, just like what happened with the valve, atrioventricular valves. So you may hear a systolic murmur that radiates to the carotid artery and the apex of the heart. So you want to do an ECG. ECG findings will have left ventricular hypertrophy. For diagnostic tests, you want to do an echocardiogram, which will show that there's a small aortic valve area and abnormal blood flow will be noticed when they do the echocardiogram. So if client is on long-term anticoagulant, again, the same thing. Monitor the levels. Steady vitamin K, prophylactic antibiotic use. The regurgitation is just that the aorta is not shut when the ventricle contracts and the blood goes up. It is supposed to shut so that the blood doesn't backflow, but what occurs, it doesn't happen and the blood is backflowing inside the left ventricle, and the same thing is happening. Enlargement of the ventricle then becomes enlargement of the atrium, which then eventually back up in the pulmonary system, which is common in male, but the mitral valve is common in female. So it may accompany Marfan syndrome, ankylosis, spondylitis, syphilis, essential hypertension,